Hello, my name is Dr. Melanie Bourgeot. I'm a third-year pathology resident at Emory University, and welcome to my fifth video. Today we'll be focusing on a range of adnexal tumors that have both pink and blue components. Before we start with our first case, I just want to remind everyone that the links to the whole slide images for these unknown cases can be found in the video description. Case 1 is an excision of a papule on the face of a 6-year-old male. At low power, I can see this is a rather large lesion that involves the dermis and extends into the subcutis. However, it does appear to be well circumscribed. This lesion is composed of variably sized cysts within a sclerotic stroma. If I move to higher power, I can see that these cysts are lined by bland-appearing stratified squamous epithelium. There are also these small structures budding off of them that appear a bit more basaloid but are still bland appearing. Most of the cystic areas contain flaky keratin, like here. However, there are also some areas like this one here that have more dense, abrupt keratinization. Lastly, there are areas with a rather dramatic foreign body giant cell reaction to what is likely a ruptured cyst and keratinaceous debris. This is an example of a trichoadenoma, a benign follicular tumor with differentiation towards the infundibular aspect of the hair follicle. Like many follicular tumors, trichoadenoma commonly arises on the head and neck, particularly the face. At low power, it is composed of variably sized folliculocystic structures with scattered basaloid buds and tubules, all within a fibrous to sclerotic stroma. Dr. Doug Parker, the Dermpath Program Director at Emory, describes this arrangement as a stack of PVC pipes. Trichoadenoma shows differentiation towards the infundibular aspect of the hair follicle, which is why it looks like it's composed of lots of mini epidermoid cysts. Both of these show epidermal-type keratinization, but you may see occasional cysts with that abrupt, dense tricholemmal keratinization. Here's a case I had as a first-year resident, and I remember being so sure that it was a trichoadenoma. However, looking back, especially now, I can tell that this is very clearly a well-differentiated squamous cell carcinoma. However, you can see where I'm coming from. Some of these areas look a bit trichoadenoma-like, though there are clear areas that look infiltrative, more like a typical squamous cell carcinoma. Other features that should have given it away include parakeratosis, which you don't see in trichoadenoma, as well as these glassy atypical keratinocytes within a desmoplastic stroma. A rare entity that you might want to consider when you're dealing with a pink and blue follicular tumor is fibrofolliculoma, a hamartomatous lesion composed of a central follicular structure with thin strands of basaloid cells coming off of it, all within a fibromyxoid stroma. Fibrofolliculoma is often discussed with trichodiscoma, which is also a hamartoma, but lacks the epithelial component seen in fibrofolliculoma. Essentially, it's a big ball of fibrous root sheath, which can look similar to angiofibroma. Multiple trichodiscomas and fibrofolliculomas can be associated with Birt-Hogg-Dubé syndrome, an autosomal dominant disorder caused by germline mutations in the aptly named folliculin gene. Birt-Hogg-Dubé is also associated with pulmonary cysts, spontaneous pneumothorax, and some types of renal cell carcinoma. Some basal cell carcinomas can have follicular differentiation in anastomosing strands of cells that may appear similar to fibrofolliculoma. I believe these lesions used to be called fibroepithelioma of Pincus, and whether this represents a variant of basal cell carcinoma or trichoblastoma is beyond my expertise. So if you would like a more expert discussion on that, I've included a link to a paper in the video description. However, what I can say is that features such as artifactual clefting with mucin and larger, more atypical cells would favor a basal cell carcinoma. In addition, the stroma in basal cell carcinoma is also usually more mucinous, as opposed to the fibromyxoid stroma seen in fibrofolliculoma. The last pink and blue follicular lesion I want to talk about is pilomatricoma, which shows differentiation towards the germinative or proliferative matrical component of the root or bulb of the hair follicle. It often presents as a firm, deep dermal or subcutaneous nodule on the face of children and adolescents. This lesion is composed of two cell populations, blue basaloid cells, which give rise to pink ghost or shadow cells. Sometimes you can see intermediate or transitional cells, which usually look like ghost cells with retained nuclei. Similar to other basaloid follicular tumors that are analogous to the proliferative layer of the follicle, brisk mitotic activity in the basaloid cells is not cause for concern. The stromal component of pilomatricoma is typically vascular, with hemosiderin, foreign body giant cells, and other inflammatory cells. Multiple pilomatricomas can be associated with myotonic dystrophy, Turner syndrome, and Garner syndrome. Let's move on to case 2. This is an excision of a nodule on the chin of a 63-year-old male. And before I get started, I just want to take a moment to appreciate what a really stunning slide this is, and to thank my co-resident, Dr. Milad Dababna, for giving me this recut. He also always orders me recuts of schwannomas, which are my favorite tumor, when he comes across them, which is one of many reasons he is a great co-resident. But back to the actual case. At low power, I see a well-circumscribed subcutaneous nodule, and right off the bat I can see areas of cartilage and bone formation. We also have these areas of tubules and glands, some of which have an appreciable double layer, which I'll zoom in on right here, all within a myxoid to sclerotic stroma. Also in this stroma are scattered single cells, which are spindled, stellate to maybe a little bit plasmacytoid. This is an example of a cutaneous mixed tumor, a benign sweat gland neoplasm that is essentially identical to pleomorphic adenoma of the salivary gland. Another name for cutaneous mixed tumor is chondroid syringoma, which is a bit of a misnomer since the sweat gland epithelium usually doesn't have that tadpole or paisley tie look of a syringoma, and not all lesions have chondroid stroma or chondroid differentiation. But whatever you call it, these lesions usually present as a relatively well-circumscribed dermal nodule on the head and neck of adults, and are more common in men. The stroma in the mixed tumor can be very prominent, and varies from sclerotic to myxoid to chondroid. Embedded within the stroma is an epithelial component, which are the sweat tubules and glands, as well as a myoepithelial component, which are the scattered single cells. And these cells can have variable morphology, including spindled, epithelioid, plasmacytoid, or clear cell. Other features that can be seen include osseous and cartilaginous metaplasia. You can also see a component of mature fat, or even areas of follicular or sebaceous differentiation. If you only see myoepithelial cells without an epithelial component, then the diagnosis is myoepithelioma, which exists on a spectrum with mixed tumor. On a molecular level, about half of the cases have EWSR1 rearrangements. This is in contrast to pleomorphic adenoma, which has PLAG1 or HMGA2 rearrangements. Last but not least, there is a rare malignant counterpart to cutaneous mixed tumor, which is called myoepithelial carcinoma. In these lesions, you can see the typical features of malignancy, such as infiltrative growth, nuclear atypia, increased and/or atypical mitotic figures, and necrosis. The most reliable predictor of aggressive behavior in these lesions is nuclear atypia, but this can be subjective. Also, unlike its salivary gland counterpart, infiltrative growth alone is not sufficient for a malignant diagnosis. If you'd like to learn more about soft tissue myoepithelial neoplasms, I've included a review by Drs. Joe and Fletcher in the video description. And that's all I have for now. Please like and subscribe, and for more educational pathology content, you can check out my Twitter and Kiko accounts. Thanks for watching!